Hello and welcome to a Royal New Zealand College of Urgent Care CME podcast interview. My name is Guy Melrose. Acute flares of chronic conditions are common presentations to urgent care and can be tricky to manage. So today we are talking eczema with Dr. Amanda Oakley. So I'd like to welcome to the Royal New Zealand College of Urgent Care's podcast Dr. Amanda Oakley, who is the Adjunct Associate Professor at the University of Auckland and clinically she's a consultant dermatologist at Waikato Hospital here in New Zealand. And she is the founder of Dermnet, which is the online dermatological website, which many of you will have encountered. So I'd like to welcome you to the podcast, Amanda, and thank you for agreeing to talk to us today.
It's very nice to be here.
Now, urgent care we're not looking at chronic disease management, and a lot of dermatological conditions require the same doctor reviewing somebody with a more chronic condition to maintain adequate treatment. And so we're often seeing people who walk in for a one-off appointment and a one-off consultation. So I've chosen a few topics here which present regularly to urgent care that we need to manage acutely, but then also instill some form of follow-up and ongoing care for them. And the first condition is eczema. A lot of patients will come in having had an eczema flare for one reason or another. So my first question would be, why would somebody's eczema get worse all of a sudden such that they would need to present to an urgent care clinic?
Well, there are various types of eczema, and the ones that have flares are mostly atopic eczema with a history of starting in childhood. And that's just the nature of atopic eczema. It has a background grumble and flares from time to time. And in most cases, the reason for the flare is unclear. However, there are some known factors. Firstly is withdrawal of medication. And people run out of things. Secondly, infection, which is nearly always Staphylococcus aureus. Thirdly is contact factors. So atopic eczema results in a stratum corneum that's defective and easily damaged by exposure to irritants such as excessive water, cold, heat, soap, detergents, solvents, friction, inappropriate clothing, and many other factors. In some people, lack of sleep, which they might interpret as stress, is a trigger. The flares can be acute flares or subacute flares. So an acute flare is blistered and a subacute flare is erythematous. Both are itchy and the skin is sensitive. The patient is not usually unwell, but they may be very distressed due to the intensity of itch, which will interrupt sleep and it result in scratching, which is in itself very distressing for people. So when examining a patient, the things to look out for are a localized area that's infected. So this is going to be redder, more swollen, maybe pussy, maybe painful. Whereas the non-infected area will maybe all of those things, but is less likely to be painful and won't have pus. So if you've got exudative eczema, the fluid is clear.
So you mentioned there infective eczema. If we just narrow in on that one for a moment. Infected eczema management, obviously antibiotics are required. When do you advocate for topical antibiotics, and if so, which ones are generally recommended, and when is it a case of oral antibiotics?
Well, we don't recommend topical antibiotics in any case. They're prescribed, but unfortunately they increase the risk of bacterial resistance, and contact allergy are inappropriately used by patients. And really we're talking about antiseptics for localized infection, and more often an oral antibiotic directed against Staphylococcus aureus for 5 days, occasionally longer. The other thing that's become quite popular is use of bleach, which is antiseptic if it's strong enough, but the latest data on bleach baths suggests that it's not so much antiseptic as anti-inflammatory, which is new knowledge, and there is considerable data to support the use of bleach in a bath at a 0.005%, I think it is, a small amount anyway. It's about like a swimming pool in strength, and is good for eczema. But not everybody has a bath, in which case they can make a solution in a spray bottle and use it in the shower.
And is that something they use during the acute phase, or is it a preventative thing, or both?
Both.
So topically, things like Cristoderm, the hydrogen peroxide creams, is that a
yes, hydrogen
thing?
peroxide cream 3 times daily for 7 days to localized infection is appropriate.
How about the betadine ointment? Is that
yes,
a reasonable
betadine
one?
Can also be used. It has the advantage of being antiviral as well as antibacterial, but of course it's messy.
Okay, and the oral antibiotic for more systemic or
more widespread.
Yeah.
Or when it's the infection's inaccessible, or maybe as a back pocket script.
Okay. And what are the role of the more traditional treatments for eczema, such as their maintenance treatments, their steroids and emollients and moisturizers and the like? How do you adjust that at all during an infected phase?
Well, often you need to ensure that the patient is using the topical steroid. It can and should be used in the presence of localized infection, and topical steroid alone can clear up small infections in eczema. So antiseptic antibiotic is not always needed for somebody who's not even been using a topical steroid and the infection's not that bad. And choosing the potency is important, and the duration. So an acute flare is over in 2 weeks if you use a potent topical steroid. So we see patients that are undertreated, that they don't bother to follow in directions, and we see some who are overtreated who continue to use their topical steroid long beyond the 2-week period, when they maybe should be using more emollient or a less potent product, or continuing the same potency topical steroid but at reduced frequency. So we might have a patient who's presented several times over 6 weeks with acute flares, and he's only used his topical steroid for a few days now and then. It would be better that he used topical steroid maybe twice daily today, then once daily for the next 2 weeks, then twice weekly, with the aim of reducing the number of flares.
So it's a concern by some people I've spoken to about using too potent a steroid. So how do you approach the kind of the ladder of potency with steroids, and what are the real no-nos for us when we're using these?
It is complicated. I think we see both underuse and overuse of ultra-potent and potent topical steroids, and really underuse is more common. So we see faults from prescribers, pharmacists, and patients. The patients can get quite nervous when they're told that they should be careful or they should use it sparingly, and they can then misinterpret that, and we end up with people who use just a tiny bit now and then, but then you discover now and then is actually 3 times a day, and they'd be much better off with using it liberally once a day for 2 weeks, and then twice weekly if they're still getting flares. And the potency depends on the severity of the presentation and the body site. So facial, axillary, and genital skin is very thin, and topical steroids will more rapidly cause adverse effects such as atrophy. And nearly always atrophy is found in those sites rather than on the trunk and limbs. And even if I do find it on the limbs, which is occasional, usually the patient hasn't noticed, which is interesting. So we're talking about ultra-potent topical steroid for very severe eczema on the trunk and limbs, but as usual treatment for the palms and soles. Clobetasol propionate or betamethasone dipropionate in the optimized vehicle. The potent topical steroids are betamethasone valerate, methylprednisolone acetonate, mometasone furoate, and these are suitable for most flare-ups of trunk and limbs. And then we have the moderate potency topical steroid, which is clobetasone butyrate, only available as a cream. Triamcinolone acetonide, cream and ointment, and hydrocortisone 17 butyrate. And these can be used for short periods of time, even on the face, genitals, and axillae, but generally not for maintenance. Choosing which vehicle is also problematic and needs to be discussed with the patient, because there are patients who say, I won't use a cream or I won't use an ointment. And you can't tell till you ask them which one it is. But generally, for an acute flare, we're going to start off with a cream because it's a blistered, swollen skin that needs cooling down. But then the cream might sting because of preservatives. In more chronic disease, we're using ointments for the dryness. Sometimes I'll give a tube of each and get the patient to work it out. The potency is greater in an ointment base, but if they're not using it, then they should have a cream base.
Okay. So in an urgent care setting, we're more likely to be using the cream because, as you say, it's the acute flare. The other thing with urgent care is we're going to only see this patient once and then encourage them to go back to their GP. So prescribing too much of a supply might not be in the patient's best interest.
Yes, and you might want to keep it simple.
So prescribing less to encourage follow-up with their GP is one option available to us, I guess. If we give them too big a supply, then they're going to go off and not get the follow-up that's probably advised.
And how much is the supply? And I think that's very difficult because we don't know if this flare is going to respond quickly to treatment or not. And working out the body surface area to which you're prescribing is also a problem. And many doctors just write the name of the prescription and don't write the quantity. And that then gives the pharmacist a burden because they're not sure what to prescribe either.
So when somebody writes the word sparingly on a script, what do they mean by that? So what would you want somebody to write in terms of...
And we would rather they didn't write sparingly. In the acute setting, we need generous. But there is, unfortunately, a requirement that the tube has this written on it. And the National Formulary has had difficulty in putting the wording suggesting that acute care of eczema requires generous topical steroids, and sparingly really means infrequently rather than the quantity.
Okay. So we should instruct patients to put a decent covering, like like you would a sunscreen kind of amount. How's best to describe to a patient per area?
Yes, to put plenty on. So the prescribing amounts are done by the Finger Tip Unit, and you can look that up on Dermnet when you're trying to work out how many tubes to prescribe. For example, a 30-gram tube might last a month. which if you're doing a 2-week supply would be 2 months. And working those things out is quite complicated. So 30 grams is suitable for the palm of the hand, really, probably for a 3-month supply, but it wouldn't be enough for the entire arm for that period of time. So if it's urgent care, you're just looking after the next 2 weeks, then those quantities will be less.
And when talking about steroids here, is there ever a role in flares of eczema, whatever the cause of the flare, for oral steroids rather than just topical?
We do use oral steroids more than is recommended in guidelines, and that's probably because our patient adherence to topical recommendations is not all that good, and convenience of tablets. But ideally, we would be considering oral steroids in somebody with erythrodermic eczema, or unusually severe for that patient, and generally for not less than 10 days. Unlike in asthma, when 3 or 4 days may be sufficient, that is not sufficient for the skin. And 10 to 14 days is going to be necessary for an acute flare that's bad enough for prednisone. And 40 milligrams daily is the usual dose. So if it's not bad enough for 40 milligrams per day for 2 weeks, then you probably shouldn't be prescribing it.
In terms of emollients and kind of moisturizers, often patients will arrive with a bag full of lots of different ones, from Sorbolene and aqueous creams. And do you have a preference? Are there any that are better than others to be prescribing?
Sorbolene and glycerine is a very good overall, if in doubt, choose this one choice. I like Sorbolene and glycerine because the glycerine gives it greater moisturizing effects than acetamacragol on its own, because Sorbolene is acetamacragol. And aqueous cream is related as well. So Sorbolene and glycerine also comes in a pump pack, which makes it more hygienic and convenient to use. But it's not greasy enough for very, very dry skin when we're going to choose fatty cream or 50% liquid paraffin, 50% white soft paraffin.
And the instructions for this is apply liberally, and can you apply it too often? Is it
Can you apply an emollient too often? Yes, in that some people get a folliculitis due to the occlusive nature and maybe excessive hair. But if that hasn't happened, then probably the more the better.
And one final question I've just thought of relating to the steroid use. I've heard it said before, often by patients, and I was wondering if we could maybe dispel this as a myth, that because you've mentioned it's safe to use steroid creams in the presence of infection, and in some cases it may help resolve things without the use of any other treatment. So patients have said to me, I've been told that steroids feed infection. Is that the case?
They can increase dermatophyte infections. So if a topical steroid is inappropriately applied to a tinea, then the result is ongoing tinea, reduction in symptoms, so itching may be controlled by the topical steroid, encouraging ongoing use, whereas the infection is getting worse. But that's not usually the case for bacteria.
What are your thoughts on the combination creams that have steroids, antifungal, and antibiotic preparations in the sort of there's MyCream and Pimafeucort and those sorts of drugs? Are those just a convenience for us, or is it?
I deal with those two separately. My Conazole hydrocortisone cream has value for flexural rash. So I'm talking about an intertrigo, not normal eczema. There's no role to miconazole in normal eczema, but in intertriginous areas, certainly there is. The triple product that contains an antifungal, an antibiotic, and a topical steroid is not something a dermatologist would prescribe. I think the only exception in my case might be for an angular cheilitis, where we have an irritant dermatitis due to saliva. We have Candida albicans, a common oral commensal, and Staphylococcus aureus is not infrequent in fissured angular cheilitis. 3 times a day for 7 days, then throw the tube away. But I don't see it of value in flares of eczema or pretty much anything else. I would just like to point out that some flares are not due to bacterial infection, but we have, particularly this year, seen a lot of herpes simplex flares. Now, that doesn't cause eczema. It's a separate thing called eczema herpeticum, which occurs in people with atopic skin, and they may not actually have eczema at the time. And they present with an acute blistered eruption. It's monomorphic. The blisters have central umbilication, and it's usually asymmetrical and localized. The patient has not usually had a history of anything similar. They're usually a little bit unwell, may have lymphadenopathy, and it's a painful rash. Mostly on the face, but it can be on the neck or limbs or anyway. And that's worth identifying because it doesn't respond to antibacterial, it doesn't respond to topical steroid, and you're looking at identifying and treating with antiviral. That's acyclovir or valacyclovir.
So that might be something that presents to us because treatment has failed elsewhere and the patient's getting fed up of not improving. Do we identify that from the history, or do you actually identify it through performing an herpes swab?
You'll wait several days for the swab. That's a bit late. I think knowing it exists, your patient is going to be in the acute phase because they're unwell, painful rash, something they never had before. If it's involving the mouth, as it often does, they're probably not able to swallow with any comfort. Its clinical appearance is pretty classical. Look on Dermnet and you'll see lots of pictures.
So I have a high index of suspicion. You say you're seeing a lot of it at the moment. Is there any particular reason?
Maybe because we are in more close contact with our referring general practitioners than was the case previously due to our teledermatology.
So in terms of eczema flaring, and we can treat somebody on the day acutely and then encourage them to get follow-up with their usual general practitioner. It is important, isn't it, from a dermatological point of view, that this person has a regular doctor who sees them with their condition rather than doctor shopping all over the place. And how can we maybe instill that into our patients better to convince them that it's, rather than them turning up with a shopping bag full of multiple different treatments from multiple different well-meaning but multiple different doctors?
I can only strongly agree with you that chronic disease should be managed by consistent care, and patients are frequently prescribed multiple products, and they can sometimes get so confused that they don't use any of them. I'm not sure how to persuade patients to go to the same doctor, but it's a good idea.
Probably one of the best tips I would have is prescribe just enough for that 2 weeks. So go to Dermnet and work out the fingertip units. Make sure the patient is told this is only going to cover you for the next 2 weeks, which is plenty of time for you to review with your GP. Because if they say, well, I can't get into my GP for a week, well, if they phone them that day, they can have that appointment within 2 weeks when the creams will run out, and then hopefully the GP can then continue the care. In terms of preventing eczema flares, we mentioned the bleach as a preventative thing as well, and you'd encourage patients to do that. How often as a preventative thing is it?
Twice a week.
Twice a week. And is there anything else that they can do other than use the medications as prescribed?
Sunlight is good, as long as you're not very fair-skinned, when we're going to be worrying about sunburn and obviously eventually skin cancers.
And one final thing on eczema, is there a role for antihistamine medications for the associated itch that they'll often have?
Unfortunately, eczema is not mediated by histamine at all, so it's not useful in most patients with eczema. But some of them have some form of urticaria as well, and if they do, then the antihistamine is useful to control the urticaria, thus reducing the scratching.
Okay, so I think that covers eczema flares. Amanda, thank you for your expertise and wisdom, and we'd encourage everybody to pop over to Dermnet and review the copious amounts of information there on this topic. And you've mentioned teledermatology. People should be looking into their local teledermatology service if it's available, and utilising that if it's available. But it's becoming increasingly available, isn't it, around certainly around New Zealand and around the world.
There's pockets of enthusiasm for teledermatology and other areas where perhaps they have more face-to-face dermatologists, and the dermatologists don't see the need to provide an internet-based service.
Okay, so if you've got it, use it. But if not, Dermnet is there with lots of information, lots of pictures, and the like. So for eczema flares, Amanda, thank you very much. My thanks to Amanda for talking to our podcast. We have a couple more talks with her that will come out in the coming weeks. I will link in the show notes to the relevant pages on dermnetnz.org and to the Bleach Bath advice pages. If you have any comments, questions, corrections or suggestions, please email podcast@rnzcuc.org.nz. Now we'll be back in a month with another CME interview, and we will have our regular weekly podcasts in between. So I look forward to seeing you all then, but for now, thanks for listening. The information discussed in this podcast was intended for the ongoing professional development of qualified health professionals and should not be used for self-diagnosis. For any personal medical concerns, please consult your usual doctor.